Hello, I'm Dr. Thomas Deering from the Piedmont Heart Institute in Atlanta, Georgia. And I'm here on behalf of the Cardiac Rhythm online community, on behalf of the American College of Cardiology and the Heart Rhythm Society. Today I'm privileged to have as guests Dr. Gillis, who is the president of the Heart Rhythm Society. She is a professor of medicine in the Department of Cardiac Sciences at the University of Calgary. I also have with me Dr. Andrea Russo, who is a professor of medicine in the Division of Cardiac Arrhythmias and Cardiovascular Medicine at Cooper University in Camden, New Jersey. Our topic today is related to pacemaker selection. Dr. Gillis and Dr. Russo are the co-chairs of the recently published consensus document by the Heart Rhythm Society on pacemaker device selection. So, Dr. Gillis, Dr. Russo, what was the rationale behind the need for this particular document at this time?
Well, there were issues related to reimbursement, related to CMS reimbursement for dual chamber versus single chamber pacemakers, and this is all based on the national coverage determination that dates back into the 1980s. Since that time, there have been several multiple randomized clinical trials comparing single chamber versus dual chamber pacemaker pacemaker implantation versus or mode selection in patients who have sick sinus syndrome or even AV conduction disease. So the impetus of this document was to provide a state-of-the-art review of the literature and to come up with specific recommendations for mode and device selection in patients with a variety of different indications for pacing.
So the assumption is that these are already patients who meet existing criteria for a pacemaker, and you wanted to elaborate further on some of the particular selections for single versus dual and type of programming features. Is that correct?
Exactly. So these are patients who have met indications for pacing based on the 2008 device-based guidelines, which includes, as part of that document, pacemaker indication. So this is not, this is specifically what type of device would you implant, dual versus single pacing system in patients who already have an indication for pacing, who have already, you've made that clinical decision to place a device.
Dr. Gillis, you have a number of breakouts, the sinus node dysfunction patient, the AV nodal dysfunction patient, and other categories. What, in your opinion, are the key take-home points for the practicing clinician in terms of how to use these suggestions in their clinical arenas?
I think the key take-home points are that, for instance, in the setting of sinus node disease, we recommend implantation of a dual chamber pacing system over an atrial single chamber pacing system or a ventricular single chamber pacing system with a few caveats. And that's based on the results of a number of randomized clinical trials showing the benefit of dual chamber pacing for prevention of atrial fibrillation, some data supporting improvement in quality of life in those patient populations. We make some specific recommendations that atrial single chamber pacing may be beneficial in some patients, say the younger patient with normal AV conduction who may not need to be paced much of the time. But for instance, the DanPace study demonstrated that there was a high incidence of progression of AV block over time in individuals who were candidates for single chamber atrial pacing, suggesting that dual chamber pacing should be considered at the initial time of implant because of the desire to reduce complications related to a revision of a procedure at a later date because of AV block. And then, of course, in those patients who develop or have permanent or persistent atrial fibrillation where no intent is planned to restore sinus rhythm, we would recommend a ventricular single chamber pacemaker. In the setting of AV block, we make the recommendation that dual chamber pacing is indicated. We also make recommendations that single chamber ventricular pacing can be considered in certain clinical situations. And again, recommendations specific to single-chamber ventricular pacing in the setting of persistent or permanent atrial fibrillation. And with the other indications, those recommendations are perhaps less robust because they're not supported by large randomized clinical trials, but the writing group felt that such clinical trials will never be conducted.
Thank you very much. I think one very nice thing about the paper is at the end you both bring up, and the entire group does, a number of clinical conditions that are operative on patients and all the individual factors that we have to utilize on a day-to-day basis when making decisions like patient age, comorbidity, cost, use of pacing, et cetera. Could you, one of you, elaborate on that and give some, direction and some thought? Because this is very nicely done and I think has a significant impact on how physicians will potentially practice.
Yeah, we thought that was particularly important to bring out as with guideline documents, this consensus document is something to utilize as a guideline. It's not saying that you must do it this way all the time, and you need to take into account other patient situations, comorbidities, and particularly patient preferences. So there's other things when you're treating an individual patient you take into account, and we do recognize that things are not black and white, that there will be some exceptions that you may elect to have a lower level indication, and you may go with for example, a single chamber atrial pacemaker for a very young patient who has sick sinus syndrome and intact AV conduction, may require multiple devices throughout their lifetime to try to minimize the amount of hardware if they're not likely to use it up front. So values and preferences and other comorbidities need to be taken into account.
It's a very good point. In addition, this whole field is one in evolution. The guidelines change over time based on the available data. Dr. Gillis, what do you think are the next areas of interest or importance in terms of device-based guidelines that clinicians will have to start paying attention to as a number of other documents come out in the near future?
Right. Well, one of the things to emphasize that this document does not address the issue of cardiac resynchronization therapy for heart failure patients. And there are a couple of important documents that will be coming out in the fall. One is a revised, an update on the pacemaker indication, not just pacemaker, but device indications, and that will include a focus on CRT. And then there's another document coming out on management of heart failure, and then appropriate use criteria that Andrea has worked on behalf of the ACC, and so maybe you want to comment a little bit about the appropriate use criteria.
As part of appropriate use is how taking into account how specific scenarios that may, there are gaps in the guidelines, that there may be specific scenarios that are not specifically, or not addressed in the guidelines. And one of the areas covered in the document is CRT therapy and how you might deal with individuals who aren't specifically addressed.
Yeah, that's a very important document, and we're all very anxiously awaiting to hear what you and your group come up with on that. Did either of you have any additional thoughts at this particular point in time on the paper?
The only other thing I want to just mention is that this document, the consensus statement, was developed for pacing indications, and I think that we need to be careful that this is not necessarily extrapolated to patients with ICDs. So these are for pacemaker patients, and there might be, in certain situations, other considerations that are important for device selection in that separate population.
Very good point.
The other point I would make about this document is I think we're very proud that it's an international document. We had a couple of members of the writing group from Europe, representation from the United States, myself from Canada, some representation from the Society for Thoracic Surgeons as well. So it really is a comprehensive document bringing a more global perspective. So although Andrea mentioned that what has driven this is in large part this ancient national coverage decision for pacemakers that stated that the prime indication for a dual chamber pacemaker was demonstration of pacemaker syndrome. It's a recognition of the expertise where the clinical trials have evolved to further inform us about the benefits of dual chamber pacing and the fact that we have a more global perspective and support for the recommendations, I think strengthens the value of the recommendation.
And would it be your thought and hope, Dr. Gillis, that over time we have more of a multidisciplinary and global approach in how we deliver care to patients irrespective of their geographic locus?
Absolutely. I mean, one of the things I'm proud about is that the Heart Rhythm Society, with our next consensus document, is partnering with both the European Heart Rhythm Association and the Asian Pacific Heart Rhythm Society on a document on the management of heritable arrhythmia conditions. And that's a recognition of the global nature of cardiac disease and the fact that organizations like this partnership with ACC and HRS are so important to educate our allied professionals as well as our physician colleagues to get the message out there and treat patients appropriately.
Well, on behalf of the Heart Rhythm Society and the American College of Cardiology, Cardiac Rhythm Management online community, I want to thank you very much, Dr. Gillis, and thank you very much, Dr. Russo, for taking the time to be with me today to discuss these implications for the practicing clinician. This document is very important and I think will significantly add to the care which we can all render to our patients. Again, thank you both very much.